Hello, everyone. Welcome to Group 7's poster intervention on reducing adolescent e-cigarette and tobacco use among adolescents aged 12 to 17 in the United States, and this is a school-based stimulated intervention. My name is Hira Harun, and I will begin by the introduction. E-cigarette use among adolescents is a significant and growing public health concern, with approximately 2.1 million youth currently using these products. Adolescents aged 12 to 17 are particularly vulnerable as ongoing brain development increases their susceptibility to nicotine addiction and long-term cognitive and behavioral harm. A key driver of this issue is the widespread misperception that e-cigarettes are less harmful than traditional tobacco products. This low perceived risk reduces adolescents' sense of susceptibility and severity, making them more likely to initiate use. In addition, peer influences and social norms continue to reinforce vaping behaviors among youth. To address this, our intervention is grounded in the socio-ecological model. At the interpersonal level, it targets low risk perception through education and counter messaging. At the interpersonal level, it incorporates peer led strategies to reduce social reinforcement. At the organizational level, which is where we'll be focusing, schools provide a structured setting to deliver consistent preventive programming. The goal of our intervention is to reduce e-cigarette and tobacco use among adolescents aged 12 to 17 in US middle school and high schools by 25% within 6 months through peer-led and school-based prevention strategies. We'll now hand it over to my teammates to discuss the target population and intervention design. Please enjoy. Thank you.
All right, so building on the goal of our intervention as described by my colleague, I will now be talking about the target population and participant selection, which includes our exclusion criteria, inclusion criteria, and size of our intervention cohorts. All right, so our intervention focuses on adolescents aged 12 to 17, as this is a key period when many individuals begin experimenting with e-cigarettes and tobacco. The setting is middle and high schools in the United States. This allows us to reach this group in a very structured environment. We selected a sample of 150 students, which is appropriate for a school-based intervention and allows us to effectively evaluate our outcomes. So for inclusion criteria, participants must be between 12 to 17 years old, enrolled in the selected schools, either currently using e-cigarettes or tobacco within the past 30 days or identified as being at risk as well. Our exclusion criteria includes students who are already enrolled in formal cessation programs or receiving treatment for nicotine dependence to ensure our results will reflect the impact of this intervention. And overall, this approach allows us to focus on a high-risk group while maintaining consistency within our study.
Hi, I'll be discussing the intervention plan and determinants. Moving into the intervention plan, I will discuss the interpersonal determinants of adolescents vaping and the theoretical framework we're using to address them. Our strategy is grounded in the health belief model. We've identified the primary driver of e-cigarette uptake is low perceived risk, where many adolescents incorrectly view the aerosol as a benign and harmless substance. To bridge this gap, the intervention targets two critical health belief constructs, perceived susceptibility and perceived severity. Since youth often minimize their vulnerability to nicotine addiction, we use evidence-based counter-messaging regarding toxic chemicals and brain development to make these risks feel immediate and personally relevant. We also incorporate other health belief layers for a comprehensive approach. Cues to action. High-impact media and school visuals serve as external triggers to prompt behavioral consideration. Perceived barriers. By reframing vaping as an addictive rather than safe trend, we increase the psychological resistance to initiation. Self-efficacy. Our messaging reinforces refusal skills, building the confidence necessary to resist peer pressure. By aligning these methods with interpersonal factors, we aim to replace misinformation with heightened sense of risk and ultimately lowering experimentation rates. Now I'll hand it over to Renee to go over objectives.
I'll be discussing the objective of our intervention, which focuses on addressing low-risk prescription cigarette use among adolescents. And this is a key factor for influencing initiation. To measure the effectiveness of our intervention, we develop several SMART objectives. Firstly, we aim to increase knowledge of health risks associated with e-cigarette by 25%. We also aim to increase perceived susceptibility and severity by 20%, helping students by understanding how vaping can impact their overall health. In addition to this, we aim to reduce common misconceptions. And some of these misconceptions may be the belief that vaping is harmless, and that would be by 30%. And finally, we aim to decrease the intervention to initiate e-cigarette use within the next three months by 20%. As shown in the flowchart diagram here, our intervention follows a progression from increasing knowledge to improving risk perception and ultimately reducing the intention to vaping. These objectives are supported by our intervention component, and it basically includes class-based educational sessions, counter message media campaigns, interactive busting workshop, and together these strategies work to increase awareness, correct misconception, and reduce the likelihood of e-cigarette use among adolescents. So I'll now pass you over to Malik to further discuss this matter. Thank you.
Hi, my name is Bridget, and I'm going to briefly walk through our intervention design objectives as well as our logic model. So intervention design, our design is a 3-component school-based intervention, which is aimed to increase the perceived risk as well as prevent initiation. So the 3 components: classroom-based educational sessions, counter-messaging campaigns, and interactive myth-busting workshops. So let's go through the duration, frequency, and intensity of the components. For classroom-based educational sessions, we plan for them to run for 6 weeks, with 1 session occurring per week, with the sessions being 45 minutes each session. For the counter-messaging campaign, it's based on anti-tobacco messages in the form of posters and social media posts. The campaign should run for 8 weeks, and for the intensity, there would be ongoing exposure to these messages, with students viewing as well as creating these messaging materials at least twice weekly. For the interactive myth-busting workshops, they should occur once every 2 weeks for 4 weeks, and they should be 60 minutes each session. And these components are guided by the health belief model, and they're aimed to increase perceived susceptibility, perceived severity, and cues to actions, therefore reducing adolescent likelihood of initiating e-cigarette use. So I'm going to go through our logic model. These are the various components: inputs, activities, outputs, short-term outcomes, and impact. So for inputs, these are the resources that make the intervention possible. For example, the evidence-based curricula based on systematic reviews, the trained educators, the school counselors and peer facilitators, partnerships with various public health agencies and community organizations, the media design tools for the counter-messaging campaigns, funding and school administrative support, and also age-appropriate and culturally tailored materials. These inputs ensure that the program is both scientifically grounded as well as feasible within a school setting. So next are the activities. Input supports the 3 core activities which aim to build knowledge on tobacco and e-cigarette usage. So for the classroom-based educational sessions, activities include the lessons, teaching of refusal skills and decision making, as well as integrating social influence and life skill approaches. The counter messaging campaign engages students in creating anti-tobacco content, and the interactive myth-busting workshops aim to reduce misconceptions around tobacco use and strengthen critical thinking via role-playing. So these activities will generate measurable outputs which reflect how well the program is doing. For example, the percentage of schools implementing the program, the percentage of students who are participating, the percentage of classroom sessions delivered, the percentage of student-generated campaign materials like posters, the videos, the percentage of campaign messages distributed, the percentage of student sessions delivered as intended, so as to make sure that the curriculum is being correctly followed, as well as teacher or facilitator adherence scores. So this, from the outputs, we expect several short-term outcomes like increased knowledge of the health risks of tobacco, improved attitudes against tobacco and e-cigarette use, increased refusal skills, reduced susceptibility to initiation, and also a shift in the perceived social norms. And through these short-term outputs, we'll get long-term impacts, which include reduced prevalence of adolescent tobacco and e-cigarette use, a lower burden of tobacco-related diseases, sustained tobacco-free norms within school environments, as well as contribution to long-term public health improvements and reduced cardiovascular risk. Thank you.
Hi, everyone. So I'll be speaking about the evaluation plan and outcome. I'll briefly explain how we're actually going to check if the intervention works and also if it was delivered properly in the first place. So starting with the process evaluation, here we're basically asking, did we do what we said we were going to do? So we're tracking things like how many sessions were actually delivered, how many students showed up, and whether the content was delivered the way it was designed. We're also looking at engagement, so things like social media reach, participation in workshops, and overall student satisfaction. All of these things are going to be documented using simple tools like attendance sheets, facilitator checklists, and analytics from digital platforms. So we've set clear benchmarks here. For example, at least 85% of sessions delivered and around 80% student attendance. And this is to ensure that the intervention had enough exposure to realistically make an impact. Now, moving on to outcome evaluation, this is where we ask if it actually changed anything. So we're measuring changes in knowledge, risk perception, and intention to vape, as well as actual self-reported use. Now, this is done using pre and post surveys, plus a follow-up after 3 months to see if effects are sustained. In terms of design, we're using a school-level comparison approach to reduce bias, and we keep things consistent by using the same survey tools and standardized delivery across groups. So overall, this gives us both sides of the picture, not just whether the intervention worked, but also why it worked or why it didn't work. Thank you.
Thank you for listening to our presentation, and we look forward to your feedback. Thank you.